telling the machine your MA and your KVP, and then based off the body part that you put in, what the time should be to make your mass, right? So once that image receptor gets all the information, it turns off by terminating the length of the exposure to get the mass that you set it for. Okay? That's what AEC is. So these are the ones you select: KVP, MA, what image receptor, grid, and thicker anatomy places. And then based off those settings, the AEC will give you the mass that you set with the time. It'll stop, right? Bold lettering here, good to know. When is it terminated? When the radiation has reached the IR at the setting that you put, okay? AEC, the detectors, very important. So any amount of radiation that you set, positioning is very critical when it comes to AEC. So what are those detectors doing? They're basically turning those X-ray photons into an electrical signal and telling the machine to terminate the exposure time. That's what that detector is doing, those little cells that you see on your cassette, not cassette, but the buckies, okay? There's two different kinds of AEC. This is all familiar information, right? We kind of went over this in the earlier chapters, that first test, when we were talking about different types of phototimers. So you got your first generation phototimer, and then what's more common today for AEC is the ionization chamber, okay? These are your two AEC systems. See your cells. Boop. There's your cells. Normally 3 different detectors. You either have the 2 laterals on or the one in the middle on. So if I were doing a spine, which cell would I probably have active? The center. If I was doing a chest x-ray, the 2 lateral ones. Choosing the correct cell for the correct anatomy lets it know when to shut the timer off, so then it gives you that good picture. That's the detectors, okay? You, as the radiography, are in charge of setting that configuration. Because you can set a chest x-ray up and have the center cell on. Is the picture going to look good? No. Not going to look good. Because it's waiting for all that radiation to get to that center cell to know when to shut it off. It's hitting the spine, not lung. So it's going to make that picture look really burnt out. So make sure you're setting the correct detectors up for the correct piece of anatomy that you're trying to image, okay? Oh, two lines. Okay. So, talking about the first AEC, your phototimer. What is it? It's a fluorescent screen that converts light, your X-ray photons, into electricity. You tell the computer to shut off. Okay? That device, that's all it's doing. Converting those photons into an electrical energy. Your photodiode, solid state device, probably a concept you've heard on computers before. Don't ask me to explain it though. I said that device is performing the same exact function. So you have 2 different kinds of timers that are doing the same thing. Okay? Your PM or your photodiode. Your photomultiplier or your photodiode. Same thing on your timer. So here's an example in the picture. You have your image receptor, your light petals. So those are going to get coated with whatever fluorescence you have, usually in the image receptor. And then it's turning that X-ray photons, that signal, that light that's coming off of it, into an electrical impulse, okay? So it's going to interact with that, produce that radiolucence, and then once it's at a certain level, whatever mass you may have set, because remember this is just a different kind of AEC, how this AEC is working with this phototimer. So it's going to take that light, convert it into electricity, turn your timer on, and your image is produced. Very, very basic. A lot of complicated stuff going on, but this is the basic description of what that photo timer for AEC is doing, okay? Then you have your other version of AEC using the ionization chamber. So if you see here, your ionization chamber is above your image receptor. If you look here, you have your image receptor and these light petals underneath it, okay? They're working together. This one is detecting it as it goes through to hit the image receptor, okay? So it's before it reaches the image receptor. It's got a sensor that's detecting those photons before it gets to the image receptor to let it know this is all the photons that you asked for. So once it gets to that certain level, it's going to turn off and your exposure will be done with whatever time increment it might have set, like your mass. You set the KBP and MA, and then this picked a certain amount of time that made that mass level the amount that it needed to be to generate that picture after it hit the cells, detected it, and turned it off for you, okay? Questions about the two different kinds?
Photons actually passing through the image receptor?
I know, that doesn't make sense to me, because I'm like, the image receptor is supposed to be the be-all, end-all.
Yeah, that's what you were catching that. That's why.
The description, it's like
I mean,
converted to electricity, which trips the timer. So I'm just like, technically, we always think of the image receptor as the end, but you know those photons are going through until they get stopped. Which is why your rooms are lined with lead, because they're not always stopping at the image receptor. They're not always angled at the image receptor. They're going 360. We put certain safety measures into place so that those, that you're not dosed all the time, the patient's not dosed all the time. So that's why your tube's gonna be lined in lead. Your wall is gonna be lined in lead. Whether it's the direction that you're always angled towards the wall versus the one that's not always angled towards the wall, those require certain density level difference as well. Like one's going to be thicker than the other. These are all safety measures to stop your X-ray photons from continuing to go and go and go. So in this case, yes, those photons are getting past the image receptor, but it's still doing the same function.
Yeah.
Cutting it off to let you know all these have hit, they're ready to loosen, turn it off. That's my timer. When you get to your ionization chamber, it detects before the image receptor, but again, they're like smack on top of each other. So they're very close to each other. One just happens to be above, one's below. But they're both performing that function of turning your timer off, finishing the exposure to whatever MA and KBP that you set to make your image, based on which cells you activated, which detectors you used to produce that image, okay? So talking about your MA, combined with your seconds to do the AEC image. So the actual amount of mass, you have an idea of what kind of mass for certain images you're gonna need, right? You're technically just putting in your MA so that the machine can detect that ionization and turn it off for the seconds that it needs to produce what would have been that equivalent of mass, okay? The machine knows that if your picture is not good, and this is the mass that you have, and you use AEC to make this picture, right? That was the mass you were expecting for the AEC, for those detectors, and your picture still doesn't look great. Look at your readout, because your second picture, if you have to repeat it, should not probably be AEC again. Because if your positioning was correct, and your image still doesn't look great, if your mass was what you set it for, but the image still doesn't look great, repeat on manual. If your image was burnt out, maybe reduce the mass that you saw. If your positioning was correct, then the repeat is all about manipulating those factors. If your repeat is needed because you had the correct cells on, but your positioning was incorrect, then yes, by all means, leave your AEC on for that repeat. But if it's all about your technique not making that image look good, all the other factors were ideal, like you thought that was a good mask for their habitus, you thought the imaging, they're perfectly centered if we're doing a lumbar, but it doesn't look good, and you collimated well, you tried to reduce the scatter as much as you could, look at what that mass readout is on the AEC, switch it to manual, and maybe increase your technique. To do a manual technique, repeat picture, and get that better diagnostic image, okay? Because that's y'all's job as a radiographer, is learning what do I need to correct to get the best diagnostic image. AEC is great, but if it's not utilized properly, you're not always going to get the best picture. Know how to fix it if you can. Know if it was underpenetrated and flip it to manual and increase your technique. Okay? That's all it's saying. Just look at that readout and see how you need to fix it to make the best picture. Okay? Alright, picking your KVP and your MA. Higher KVP, less dose for the patient, right? AEC, decreasing the exposure times, because obviously that AEC is going to trip it way faster than you as a human could stop the exposure, right? So these are all manipulations that are done to save the patient dose, okay? But there's still a certain amount of mass needed to make a good exposure. So know your combinations of your MA versus your time versus how is your patient acting. Are they a small patient? Are they a large patient? Are they moving around or holding still? These manipulations, like we did the math before, where you can have a different combination of MA and time equal the same mass, but it might be a faster exposure. It might be a slower exposure, but with more photons. It just depends on what you're manipulating, what the patient looks like, what the timing is going to need to do that good picture. Does that make sense? Same mass, but you could have a different equivalent of MA to time to equal that same mass, okay? Know how to manipulate these things. Know that if your mass was good, your photons were good, but you still want to kind of decrease your exposure, you can manipulate with your KVP. That 15% rule, we can put that into play too. These different selections will help you become a better radiographer on reducing your dose, but still getting that diagnostic image quality that you need, okay? Play with your numbers. Look at the readouts that are occurring when you're taking the images, or watch the readouts when if you have one of those techs who is constantly bumping it up or bumping it down, ask them why they're doing that. Try and learn what it is that they're manipulating that they think they need to play with it. Is it because they know that in this particular machine, the exposure is always hot? Is it because they know that they're using a really high grid ratio? That they know they need to increase the KVP? These are the things that we're learning about. To ask them, don't just watch them hit the button. Ask them why they're changing that, okay? So, your response time. Obviously, the shorter the exposure time, the less photons, or that are shorter exposure times are going to be sometimes a larger dose to the patient, but again, it's about what is your patient doing? Because remember, if we want the same mass for a certain image, but we need to make it very, very quick, your MA goes up. Your MA is your quantity, okay? If we have the luxury of the patient holding still, maybe we can make the seconds slightly slower, which is increasing that time, so that we can decrease our MA, have the same mass with a little bit less exposure time. So your newer machines have that 1/1000th of a second quickness when it comes to their time. Are you always going to use 1 millisecond for an image? No, not everything needs the fastest exposure possible. But know what your machine is capable of so that if you do have that patient that is moving around or that pediatric patient that is just like flopping around everywhere, know what you can manipulate, how low it will go, how fast it will go, so that you can get that good diagnostic quality image, okay? This is all about, this whole chapter is about what manipulations can you do to have a quality image. What exposure techniques can I select or change or increase or decrease to get that same quality good image? Make sense?
To get the shorter exposure time. So we increase the KVP or decrease the mass?
If this is like the initial image,
Yes.
yeah, you can, like when you're talking about the 15% rule, your KVP went up by 15%, you can half your mass.
So we can reduce the time?
What? Right, because we're talking mass as a total, but it also is a decrease of time too. So I'm thinking of mass completely of MA times time. If you were only thinking of the seconds, then yes, your MA will have to go up to decrease your time to equal the same mass. Does that make sense?
Yes.
Okay.
So I guess like, isn't like, unless you do like something with like orthostatic breathing,
Mhm.
like just having the shortest possible time is probably ideal there?
No.
Just because, no? I mean, I was just thinking in terms of like
Yeah.
motion, like in terms of voluntary.
Motion, yes, the shortest time possible, but you have to remember that when you're still needing something that say needs 50 mass, right? If I have a faster time, my time has gone down.
Yeah,
To still get 50 mass, I have to increase my MA.
okay,
MA is dose.
okay, okay,
So by always doing the fastest time, I'm actually giving my patient more dose.
okay,
So that's why it's constantly a balancing act.
yeah,
That's why we love the 15% rule, because 15% rule is a higher KVP, and that means I can lower my mass, less dose,
okay.
okay?
I-
So your backup timer, hopefully this is something that never gets tripped, but basically there's that safety time machine and the fact that, is my exposure cutting off? You're talking like seconds or minutes sometimes, especially in the floor room, this can be a certain minute timer. But this is just a backup safety measure for that AEC to shut the machine off, so that one, you're not overrating the patient, two, you're not overheating the tube. So it saves the mechanism of the tube as well as the patient for safety reasons. That backup timer is built into everything. It's a requirement usually from I don't know if it's a state or a federal thing, or probably both. But basically, when you're manipulating radiation like this, you have to have built-in safety measures. That's what the backup timer is. All right, again, talking about that AEC, with those cells, positioning is critical, okay? You don't always think about it when you're going quick, but if you have the time to take that extra second to get that patient a little bit more centered, you could be saving them just a few degrees of dose. Whatever your dose output might have been, it could have been a little bit less had they just been an inch more over, right? Did the picture maybe still come out if you put the spine like right here along the outer edge of this one, as opposed to right on the dot centered? Yes, software is great today. It will make your image look pretty, whether it's a good image or not. It's kind of a double-edged sword. Yes, it will help improve your images, but that meant that your patient got a higher dose than they needed. You aren't as worried about very critical positioning because, hey, my image still looks fine. Yeah, it's fine, but you could have saved dose. It would have shut off a little bit sooner had they been accurately positioned, so that that dose didn't need to be given. Something as little as that. That's like literally your whole job is to get the best possible picture, but with the least amount of dose to that patient. So laziness and AEC often go hand in hand. So try not to be lazy about your centering. Okay? Very crucial, very critical. Move them over that extra inch, get them on the very center of the cell that you have lit up so that that timer will time out faster and get that image with less dose, just because you were very critical about your centering. Okay? It's not always something that you can see with this extra effort, but just know that it's something that even if the patient's not aware of it, you're aware of it. You know that by having them slightly off center, you gave them a slightly higher dose. Is it going to cause cancer, that tiny little bit of dose? Probably not. Is it something that you could have prevented? Absolutely. Again, centering. Being centered on that center cell, you can see all these spinous processes, all these transverse processes. It's a pretty APT spine. Your cell's right here, so as soon as all those photons hit that lung, because it goes through air real fast, it turned off, which means all these got attenuated. So that patient got a higher dose. You have another higher dose in the fact that you have to repeat it. This is not something, and you completely cropped the spine that you're looking at anyway. So this is just a bad image. It's like if I tried to do a right lung. Who does a right lung? But yeah, so the centering is all about that dose. One, the dose that you gave them for that one picture, and two, the additional dose you're giving them because you have to repeat it. Even if you don't have to repeat something, doesn't mean you didn't give them extra dose. If, say, we had actually gotten all the spine here, but it was still off center, that's still dose that you gave them. Yay, you don't have to repeat it, you can just crop it out and do that digital collimation, but it's still a higher dose than they needed. It still wouldn't be a quality image because you don't see these spinous processes nearly as clearly as you do over here when it was centered on the correct cell, that correct detector, right? So maybe it's like a little chip off of one of their vertebral bodies that we can't see because maybe I got all of the anatomy on that picture without repeating it, but the sharpness isn't there because it wasn't centered correctly. So detector size. Those cells are one little size. When you're collimating, you're not manipulating the size of the radiation detector, you're just manipulating the size of what's hitting the image receptor, not the actual detector. The only thing you manipulate when it comes to the detectors is which cells you're using, but not the size of them, okay? Oh, so I think I was talking about, so if the detector combination is larger than the area of interest, manual technique should be used, which is kind of shown here. Little boy, say I'm doing a chest x-ray. The two lateral ones are used normally on a PD or on a chest. But for a PD, he's not hitting these detectors the way he should. So I should do a manual technique for this. One, because he's a PD, he's small. And two, because he's not hitting the lateral detectors the way he should, and I cannot manipulate the size of those detectors, okay? Versus if this were an adult, none of the cells are visible. They're covered. The correct anatomy is laying over the detectors where they need to be if I was doing a chest x-ray, okay? Little things like this. If he's not hitting these lateral detector cells, could I just turn on the middle one if I'm doing a chest x-ray? Wouldn't he still cover that detector cell? So wouldn't that work? Right, it's still going through the spine. So yes, you're trying to think, how can I resolve this? But this isn't one of those cases where maybe I can just manipulate which cell I'm actively using. The chest x-rays need both sides. It's trying to punch through the lungs and then stop. Turning off just one of the cells doesn't mean you're properly positioned correctly. Manual technique. Don't be lazy. So, different ways to compensate, different things. When you're using your AEC, these are the things that you have to think of if you're going to continue using your AEC. Is the area of interest thicker? Is it smaller? Was it a ped? Was it an adult? Do they have pathology going on? Like when we were going over ascites, that is something, yes, it's the same abdomen as if they didn't have that pathology, but now we have excess fluid. AEC is going to have a tougher time penetrating that because of that fluid. Collimation is your friend. One, on reducing scatter, on reducing dose, and in this case, on helping your AEC conditions. If you don't restrict the beam, you give them extra scatter. If you don't restrict the beam, then perhaps the centering is going to be even more visibly off-center, and your timing is going to increase. Your collimation and your off-centered, say you have no collimation and you're off-center, so it's just detecting whichever beam or which detector you had on, and it's going to keep on exposing until it gets to that mass that you wanted. If you collimated down, reduce your center, or reduced your scatter, and centered the patient correctly, less dose, less scatter, and your detector times out when it should. Okay? That being said, if you collimate too closely, depending on where your detector's at, like we all like that nice tight little box for your odontoid. That's not really something we should be doing AEC for, right? Because yes, you're using that very center cell, but that center cell is kind of elongated. And depending on how tightly collimated you are, again, it's the same situation as like the PD versus the adult. And the fact that not all of your anatomy is covering that entire detector cell. So your AEC, yes, you collimated, but now you collimated too much, and your detector cell is not going to get all the exposure that it needs to time out correctly. So again, that's kind of why you hear that head work is usually a little bit better AEC, or manual, thank you, a manual than using AEC, just because where those detector cells are versus what you're looking at and how they're not exactly centered over that central detector. Make sense? So, too much collimation, too little collimation. It's going to throw your AEC off. And to demonstrate, whoop, whoa, okay, yeah. Well, that was fun. There we go. I don't know what's spazzed out. Okay, talking about wide collimation, depending on what you're looking at. Say we're at LBJ and we're doing a lumbar, and it's wide open because they don't let us collimate. All this is going to be scattered, versus if we collimated too tightly, now not all of this detector is lining up, and we run the risk of clipping certain bits of anatomy. Yeah, you were really trying to reduce that scatter, but almost to the point of not utilizing your AEC correctly and clipping anatomy. So it's always a balancing act when it comes to how we're going to generate that best diagnostic image. Okay? All right. Y'all noticed that some of your machines, you can go in and punch a hand and then punch the position. Those are automatically programmed techniques. Based on that machine and the level of calibration it's at, maybe you keep it at that kV and mass setting. Maybe you tweak it. This is what I'm talking about, like depending on where you're at and how well your machine is calibrated, based on your knowledge of what is the thickness of this piece of anatomy. Is it going to have a lot of scatter as an extremity? Not so much. When you start getting into the body, our scatter increases. Maybe our mass needs to increase. Maybe it needs to decrease. It all depends on all those factors of size, habitus, pathology, adult, PD. You could have a very large PD, same size as an adult, maybe same thickness, but knowing what we do about their growth. They have a lot more gaps between their bones. They have more bones, yes. They have more cartilage until those certain fusions are met. So even if you have a very large 12-year-old who's the same as a very tiny adult, you would still possibly use less dose on that PD. Or maybe more, it just depends. What are you looking at? Are you looking at an abdomen? Is he large because of fat? Is he large because of dense muscle? Are they large because of fluid retainment? These are the things that let you know how can I manipulate my mass to get as little dose to them, but as diagnostic a picture as possible, okay? So yes, it's nice having those automatic program techniques, but no way they're shooting hot or within range when you use them, okay? If you go into a machine that you've never used before, ask your tech, ask someone who's familiar with that machine, hey, is this normally pretty good when it comes to the dose output, or does it normally shoot hot? And with that information, you know, can I reduce my kVp, can I reduce my mass, so that I'm within range, but I've saved them dose if I could, okay? So those program techniques usually are based off of AEC. They let you do manual exposures, but there's like normally a button you have to switch to let it know to stop using the AEC detector cells and just use the entire image receptor to do the manual technique, okay? Again, that programming and the AEC are not the same thing. The programming is a suggested range of kV and mass. Your AEC is when it shuts down based off what you left it at kVp and mass. Make sense? There is a difference. Has anyone been to Aldine? Did y'all get this paper? I actually got this from Ms. Sharonda. Recommended kVp range. Recommended, not set in stone. Okay? Just an exposure technique chart. Basically, if I'm looking at a pelvis, ideally, I want to use somewhere between 65 and 80 kVp. Based on their habitus, ideally, you can use 12 to 20 mass. It's a little suggestion, it's a starting point to where once you get more familiar with that machine, once you manipulate it or you do a lot of manual techniques or you do a lot of AEC techniques, you can fine tune this chart to where it has the most ideal dose based on that person's habitus. Whether they're a PD or an adult, you can have an idea of what your first image should look like so that maybe you don't have to repeat it or manipulate anything to get a lower dose because you fine-tuned it enough to get it on the first picture. So if y'all are at Aldine or rotate through it, ask her for this picture. I actually got this from her. She gave it to me on one of the first days when I was rotating through the different clinics last semester. So Even as a teacher, there's always something we can learn every day. So I don't use manual very much. AEC is handy to fall back on. But growing as a technologist, it's sometimes beneficial to know what those manual techniques would be if I need to turn off my AEC, right? Anything you can do to help the patient. So, different charts. This is still the same one, but you will normally have some type of technique chart in that area. I know a lot of places are going to where they're not allowed to post them sometimes, just because when you do the J-code things, unless they're like properly laminated and labeled and approved by management so that you can keep it on the wall all the time, a lot of them have had to put their technique charts like in a binder, but usually there is some type of technique chart available if you know to ask for it. Everyone's had to work through that specific machine that they work on to get an idea. Even if it's maybe in that technologist's head, they have a technique chart, an idea of what kind of KVP and mass I should use based on what I'm looking at, okay? Because they've had years of training for that. Even if they don't have years, like I know there's a lot of new techs that have been taught, but they're slowly working through that to get an idea of what a good technique is for what the habitus is versus what the exam is, okay? This is something y'all work on for years. So it's good when you're always on the same machine, so you can really get that familiarity with it, but sometimes you don't have that capability of that. Just know that also your technique chart, remember, because of your generator efficiency, that expectation of what your technique should be in a room versus what it should be on a portable are going to be different, okay? Usually your portable is going to have lower doses or lower KVPs because the generator doesn't have that high quality efficiency, right? So sometimes you'll have lower KVPs but higher mass on a portable because you're trying to get the same image with that less of an efficiency. Blech, can't talk today. Make sense? All right, certain things that you can do to help with your techniques. Something that almost nobody utilizes is your calipers. You can get part measurements based on the thickness of that part. Like the most common would be what? The knee. Like depending on the thickness of that knee, the angle of the crest to the as is tells me whether I need to angle up, angle down, don't angle at all for a knee image. Calipers. Usually after doing this for long enough, you start being able to eyeball something where you don't need that specific centimeter measurement, which is good. But if you're still new enough, don't be embarrassed about whipping out some calipers to get an idea of what's the most efficient technique I need to apply to this image to get this patient out of here quickly, but with really good pictures. Bust out the calipers. That's okay. It'll help you get that better technique. All right, you got two different kinds of exposure charts. You have your variable KVP with keeping your mass the same, or you have fixed KVP and how you should manipulate your mass. It shouldn't always be one or the other. These should be interchangeable. They both have good and bad aspects of them. Like if you only have one of these posted, that's not exactly the best thing, because remember, sometimes if I have a fixed KVP chart, it's only telling me how to manipulate my mass up or down. Mass is normally dosed, higher or lower, as opposed to if I keep my mass the same and I manipulate my KVP up or down 15% maybe, less dose, better picture, but one or the other. It's not, you need both. Okay, so with the first one, the variable KVP fixed mass. This is based on the concept that your KVP can be increased or decreased based on that anatomic part, and that your mass should be your mass, it should be your mass. Not always the most logical. So, part thickness, critical, determining your baseline KVP. Again, it's not always going to be the same for every machine. They're going to have differences among different brands, portable versus room, things like that. But this will help you variable, like these different charts are just an aid. They're always a guideline, not something set in stone. Versus the other one, fixed KVP. All portable checks should be at 90. My mass needs to change based on their habitus. These are usually the most common you're going to see. More often, you manipulate mass than KVP. Most techs are usually more comfortable with that. That doesn't always ensure that the dose is going to be the lowest though, because with mass comes dose. So, optimal KVP to penetrate, and then how many photons did I want to go through. So, these can both be used. It's something to play with to get an idea of what you think is accurate. How you develop these. There's certain phantoms. Usually the reason the charts even come up based on that machine is because the initial setup of that room or machine went through calibration, physics testing. The physician came in and had a bunch of different kind of phantoms, super heavy, but different kinds of phantoms based on the dose that it produced. It lets you know with an increase or decrease of thickness part, this is the ideal optimal KVP and mass range that should be used. That's how you develop these. It can be done at the initial setup, or like what I'm trying to tell y'all, and the fact that you as students can start developing your own exposure technique chart based on things, you know, the range of what certain pictures are supposed to be at. Get an idea, even if you don't bust out the calipers to measure that patient, you can put medium habitus, small habitus, adult, or musculature adult, things like that to kind of give you a basis of, I saw this KVP and this mass on this patient, and it looked really good for my KVP. And based off that information, if I see that type of patient again, maybe ideally I could use the same techniques. It's your own development of your chart of what you think is a good KVP and mass. Up, high, low, what do you think? Okay? Was it within range? It's a lot of repetitive information, but at least this is information that's a tad more familiar to y'all, yes? Yay, we're not talking about interactions with matter. This is just something you can ideally visualize using at clinical, right? Little tweaks that you can make to your flow to have optimal images and ALARA. That's all this is. There's a bunch of different phantoms based on their thickness. Lets me know what kind of range or mass or KVP for KVBs, for skulls, things like that. Whether I should use AEC, or manual. This one's always going to have very little scatter, so I can use less. This one ideally is going to have a grid all the time, so I need to use more. Things like that. That's information that you're playing with. Did I use a grid? Are they big? Did they have pathology and that's why the image wasn't out of range? Or was it a good picture? Things like this, you need to make sure you annotate. Don't just always write down KVP and mass. You have to write down what were the situations that got you that KVP and mass. because they're not always going to be the same. Special considerations. Oh, take a stat. Has anyone ever actually seen anyone use it? And most of y'all just having the oh yeah? Where? Huh? Oh, very okay. Were you in the room anyways with light on? Just okay. Did they time it with the screaming? Like was it a chest or something? Or are you okay to say? Yeah. A lot of times, like if they're being held by the parent or if they're using a Picostat, there's still things that you need to take into account. If you're doing a PD, they have more bones, but they're a lot more spaced apart. So you're usually going to have less KVP, less mass. You're going to want to increase your time. Or not increase, decrease your time. You want to make it as fast as possible. And then with that fast exposure, usually, ideally, you're going to want a rotor until they take in that nice deep breath to scream again. And then take a picture, and then let them scream. Woo! Beautiful chest x-ray. But these are the things that you have to take in consideration when it comes to dealing with a PD versus someone who's quiet, whether they're old enough to know instructions versus not. How can you manipulate your factors to get that picture? Especially with PDs, to get that low dose and a good picture, and really, really hope you don't repeat. Most people will open up the collimation to get everything because they don't want to clip anything on PD because they're squirmers. But that also means if you're doing a chest or a KUB, you're still going to get scatter even if they're 2 years old. So obviously don't clip or don't collimate super, super tight, but don't leave it wide open as well. Okay? That's not how you fix that. Other considerations, geriatrics. The older you get, the less bone density you usually have. The calcium starts to deteriorate in the bones. So if I have someone who is my size, but 90, would we have the same manual technique or even the same AEC? You'd probably want to do less penetration or less KVP on that older person because their bone density is not going to be as great as someone who's in their 30s. Things like that to consider with older population. Are they going to be able to hear you when you give it instructions? Can they see everything in the low lighting that we prefer in our room? Do they need assistance getting on the table? Common sense factors, yes, but still needs to be taken into consideration. When you're doing lateral anything on a table, please add a pad. Again, their bony anatomy is fragile. Try to get them as comfortable as possible. I know we're all in a hurry and these are exams that don't take very long, but throwing on a warm blanket and having a pad on the table speaks volumes for patient care, okay? These are considerations that y'all can add on real quick and give them still the same quality x-ray, but they're happier with the experience that they had with you, okay? And again, exposure techniques definitely more often than not will be decreased the older they get. Obviously, there's always outliers of, yes, they still have a very large habitus and they're 70. But if they don't have a large habitus and they're 70, probably going to need less MA or less KVP because it's going to penetrate much more quickly. Bariatric patients, scatter big time. Anything in the body, bariatric patients, scatter. Positioning and collimation, very critical the larger they are. Sometimes if you're doing a chest x-ray and they're a super large patient, hey, you're going to leave it open full 17 by 17. You're not even doing 14 by 17 at this point. You're just trying to get their chest in there. That's not the case though. We all have the same skeleton. It's just theirs has a bigger coat. So collimation can still be taken into account even on a chest. Maybe not on an abdomen. Has anyone had to do quadrants? Not fun. But that's one of those times where that you have to remember that your original dose on your KUV, your abdomen, your centering is over the spine. So when you are doing quadrants, it is all soft tissue that is your center ray. So yes, you might still want to increase your dose and technique, but maybe not as much if you're doing quadrants versus if you were doing that same patient and just doing 1 KUV. Your quadrants might have a little less dose. Yes, you have to do like 4 of them, but because now your central ray is going through much softer tissue, your technique might not have to be as high as you necessarily think. The only thing that makes that more of a dose is obviously because the number is going from 1 to 4 probably. Other things to consider on your projections and your positions. We don't do one view on anything. We always do at least an AP and a lateral. So, taking that into account, the thickness of my AP lumbar is not going to be nearly as large as is the thickness of a lateral lumbar. I've now doubled the size of what I'm having to penetrate. It's still the same anatomy, but now I'm having to increase my technique versus the position and projection that I'm trying to generate. Common sense. Y'all know this. It's little things like this that it's like, you know, subconsciously these are obviously factors that are happening. I'm just pointing it out to make it obvious. I'm going to do an AP 70 at 5. I'm going to do a lateral, maybe 70 at 12 or 70 at 10. And then be very adamant about making sure that the bony structure is centered on my lateral versus maybe positioning a little bit too anterior and all that soft tissue on my lateral L spine got exposed. And then still didn't look pretty because I didn't collimate and my centering was incorrect. So just little things like that that you can help. Bone clinic. Is there a splint? Is there a cast? What's it made out of? If it's a splint, is it dry? Is it wet still? This is going to change your penetration value. If it's an air cast and fiberglass, it penetrates like nothing. So you might not necessarily have to increase your technique. But if it's like a wet splint, or it still hasn't hardened yet, or why you would have an aluminum splint, I don't know. But wood, say you've got some camper that just got rolled in for a trauma and my friend splinted it with like a broom handle. So bam, they're splint together. Now I have like something very thick and dense to penetrate through. So my exposure factors are going to change. Is the cast plaster? Is it fiberglass? Knowing one versus the other, just by looking at it, can let you know. I'm going to obviously do a little bit higher of a technique as opposed to no cast or splint, but based on this cast or splint, is it going to be a lot or a little bit of a change? Different pathologies. I know that I said ascites is a big one, a big example, in your KUV. However, sometimes you want to see that pathology. So perhaps I don't want to increase my technique on this person to blast through because I'm trying to demonstrate that they have ascites. Or say, do they have ascites and I'm trying to do a lumbar? There's two different concepts going on here. If they have ascites and I'm trying to do a lumbar, I'm going to increase my technique because that's more volume, more liquid, more mass that I'm having to penetrate through that's going to attenuate and scatter. But if I'm doing a KUV and I want to show the doctor that this additive disease is present and I want to demonstrate it, I might not necessarily increase my technique because I want to show them that they have that. Does that make sense? And then knowing, do they have RA, rheumatoid arthritis? Do they have any kind of disease that you shouldn't be penetrating as much? Not always a geriatric patient to take into consideration. Diseases happen to every age range. So, but knowing what that disease is doing, have a basic understanding of what certain pathologies are doing to the body can let you know how I can manipulate those techniques to make that good picture. Soft tissue. This isn't the best. I think it's better in your book. But if you look at the throat, how your penetration occurred here, my centering was off, my soft tissue got burnt out, versus this is super pretty, the centering's on the bone, it's visualized well. Am I doing a soft tissue versus a cervical spine? This is going to change my factors and my collimation. So these different factors come into play in taking pictures to visualize that pathology, okay? Just understand what the photons are going to interact with and what you're trying to demonstrate, okay? Other things to take into consideration, adding that atomic number. If you have soft tissues that you're trying to highlight, which are normally super gray, add a higher atomic number so that they will be attenuated better, so that you can see that digestive tract more clearly when we add barium or iodine. Things like that. Knowing that you're going to have a lot of air versus a lot of barium, so you're going to have a combination of attenuations here. That your positive contrast, your barium, your high atomic numbers, they're going to produce more densities. Your air, your low atomic number, your negative contrast, less density. It's going to be penetrated more quickly. So this to take into consideration, okay? That is all. How much time do we have?
5 minutes.
4?
I have a question.
Yeah.
You gave us the rubric for chapter 13, but on the exam and on the syllabus,
No, that's what he was telling me. Apparently,
it's 10 of them.
it might have been labeled wrong. So we have 10 and 11 from Bouchon and 12 and 13 from Faber. I've given you chapter 12 from Faber. Basically, has anyone, I saw you going through it. Were you looking at chapter 12 Faber? You're actually on it right now. So all the information, has any of it new popped out to you that I didn't really go over with chapter 11 from Bouchon?
It's got everything. It's like
Scatter.
the same.
I got some
Scatter.
different pictures, some different visualizations, but the information from Bouchon 11 and Faber 12, they're both over scatter. They're the same concepts, it's the same information. I went ahead and made 2 separate PowerPoints for those of you that, if the visualizations that I gave you on this one, maybe they're a little bit better on this one. The information is the same, but maybe the visualization of it is a little bit more clear for you on one versus the other. So yes, we are going to test over 4 chapters. However, 2 of those are the same information. Okay? So 10 and 11 Bouchon, 12 and 13 Faber. Study the PowerPoints. I'm sorry you have so many tests this week. But we have to stay on task. I'm okay with us not really discussing or not having enough time with